This is one presentation which I gave at one of the CME organized by Kanpur Ophthalmic Association, and this is on one of the most devastating complications one can have after surgery. So talking about endophthalmitis, suspecting and managing it. So when you have post-op endophthalmitis, there's a spectrum of severity at presentation, and here we have three photographs which depict the same. So we can have a situation where the eye is quiet, there's hardly any congestion, but we can see that there's some haziness at the level of pupil. It must be in the cornea or in the anterior chamber, and we can also appreciate a hypopyon here. And then we have another category where the reaction is more severe. There's starting of corneal involvement, and the anterior chamber is full of exudates. The pupil, there's a membrane, and this is worse than the previous category. And then finally a situation where there's hardly anything can be done, and there's scleral necrosis present, and the cornea is grossly involved. So diagnosing post-operative endophthalmitis. So this is what a picture of a good cataract surgery would look like on day 1. You can appreciate the cornea is clear, the anterior chamber appears clear, as you can see the iris pattern very clearly. The pupil is dilated, probably because of mydriatic, and there is a IOL which is centered, and media appears clear. But then when we are suspecting endophthalmitis, we have to be sensitive to these symptoms and signs. The first thing is unexpected pain. Now this is one patient who was operated for scleral buccal surgery, and we all can expect that these kind of patients would have manipulation of the tissue. All the 4 recti muscles are dissected, and then there is a external tamponade suture onto the scleral surface. So the post-operative picture is very grossly lid edematous conjunctival chemosis, but even these patients don't have any pain. So a cataract surgery which is so very minimally invasive, a patient should not have pain, but if he or she has pain, that is an alarming sign. Presence of chemosis. Chemosis can be defined as swelling up of conjunctiva due to imbibing fluid, and there may be a gross chemosis just like this patient. There can be lid edema, and lid edema is one of the very sensitive signs in a post-operative case of cataract. If there is lid edema, which can be easily discerned by looking at the other eye and comparing them, and that's a very early sign of endophthalmitis. Then presence of hypopyon. Now in this picture we can appreciate that the hypopyon is just merging up with the inferior sclera, and this is why hypopyon is usually hidden, and one has to actively look for it if one doesn't want to miss it. So these are the signs where one has to be very sensitive on post-op day 1, and one should watch for them, and if any of these is present, then that is an indication that we are probably looking at some amount of increased inflammation, which may be just a reaction, or it may be a suppurative infection. Now what can be done to prevent this catastrophic event? One should have an investigation checklist before executing the surgery, and strict compliance to be ensured by the designated OT staff. So whatever precautions one is using, they can be printed out in form of a checklist, and one has to be dependent on that checklist to be cleared. Only then the patient is shifted to the OT. Identify a reliable brand of consumables used during the surgery and stick to it. So it may be that for saving some amount of money, one can opt for cheaper products, but then one has to test them over a period of time and then only stick to them. And ensure a system to validate and document the sterilization process, and most importantly document it. So there should be some kind of sterilization marker, some indicator tape or indicator strip which is used on a drum or any content which is sterilized, and that same indicator strip is then documented in a chart in a register where the date and batch of that drum which was sterilized should be documented and kept as a record. One of the common reason for post-operative infection is from the patient's flora. So personal hygiene of the patient, the OT staff and the surgeon has to be ensured, which we usually are all aware of. Stick to the OT sanitization and cleaning as per the recommendation, and this will save the day. And for these things, one can easily depend on guidelines issued by our societies, maybe local society, maybe the national society, and we can all depend on them because they are being endorsed by the society, so they do have a legal standing also. Now coming to management of post-operative endophthalmitis, there has to be a high index of suspicion. One should believe that infection can occur in their own cases also. Then only it is possible to catch these cases. There has to be a earliest possible diagnosis which will make a difference in the outcome, and post-operative day 1 and day 7 visits are a must. One can also keep in between a day 3 or 4 visit, but in my experience I have seen that if you are vigilant enough on day 1, the requirement to see the patient on day 3 is not usually needed. The patient should be advised to note any deterioration in vision after he has been sent home, and if there is any deterioration, patient should report earliest possible time. And one should always look for the signs discussed earlier, and I'll repeat them: unexpected pain, poor vision, chemosis, lid edema, and hypopyon. Once you have had this event, then what to do? It's very important to keep the patient and the relatives in the loop. So I usually, when I have to explain the situation, first thing which I do is I call upon all possible attendants who are there so that they can be explained the situation, and they have to understand the situation, and so this explanation has to be in very clear language. Consent for any subsequent procedure. So you can have two options now. When we have a reaction or endophthalmitis like picture, the patient should be told, and if the patient is to be managed at the center, then consent has to be taken. Seek second opinions and referral as needed if you are not a posterior segment surgeon. Communicate and provide documentation when referring. I mean that the patient, if he is being referred to another doctor, we should be talking to the doctor, letting him know that the patient will be arriving and what is the condition. This will not only help the patient but also keep the patient, doctor, and yourself in the loop so that no unwanted messages are broadcasted. So if we have a patient with us who has had a significant amount of inflammation on the day 1 post-op, what to do? So early detection: mild inflammation which consists of minimal pain, minimal congestion, vision better than 6 by 60 or 3 by 60, cornea is clear, the incision site is healthy, the anterior chamber reaction is present which may be in form of fibrin or hypopyon. What to do then? Check for metabolic derangement. Start frequent steroid antibiotic eye drops and keep the patient under follow-up. Add atropine and a mydriatic both. So keeping the pupil dilated is very reassuring for the clinician to know that everything is under control. And daily watch these patients because you may have to take decision to stop or taper off the steroids. If we have early detection with mild inflammation and we manage the case at the appropriate time, there is very much possible to manage these cases just by adding some topical medications. And this is one example of such case where the patient had a post-operative endophthalmitis and was operated for vitrectomy, and there is a reaction here which was resolved after a while. This is another case where vitrectomy was done and patient had some amount of reaction, and the patient was kept on topical medications as mentioned earlier, and patient resolved, and we can see the exudates have started organizing in the post-op surgery day 2, where this organized exudate is a good sign that the inflammation is getting controlled. What to do if we have a frank endophthalmitis which have resulted into this kind of picture? So these patients will have pain, photophobia at presentation. There will be tenderness, congestion, lid edema, and poor vision, but it will be better than PL denied. So corneal AHES is present, but there is no infiltration, and AC has significant reaction. The pupil is stuck to the IOL, and there is a hypopyon. So what to do now? These patients should be checked for their metabolic derangements. Intensive topical antibiotics, continue topical steroids and atropine. Add systemic steroids if not contraindicated because of any systemic condition, and inject intravitreal antibiotics. I prefer vancomycin and amikacin, and the other options are piperacillin, tazobactam, and imipenem is also supposed to be having good effect because of rising resistance among the pathogen organisms. So this is the same patient after 2 days of intervention. AC wash and AC formation was done and intravitreal antibiotics were given. Patient has improved. We can see that the haze has reduced, the hypopyon has disappeared, and later on we will need some more intervention to restore the vision. But the eye has been saved. This is the third kind of situation which is late or has a fulminant course. So these patients can have moderate to severe pain, lid edema, congestion, tenderness, hypopyon, corneal or scleral necrosis, and infiltration is a very bad sign for these eyes, and the vision usually is no PL or a defective PR, and these patients have a fulminant course due to a virulent organism or systemic morbidity, and nothing can be done, and these eyes are usually destined for evisceration for managing their pain. So the visual prognosis is nil, and there is a poor chance of retaining the eye as the integrity of the globe is gone, and evisceration or conservative treatment is dependent on how severe the patient's symptoms are. So if the patient has sleepless nights because of the pain, it's better to remove the eye with the consent of the patient. If the patient has not so significant pain, then topical and intravitreal injections can be given so as to control the suppuration, and then later on the eye like these will go into phthisis bulbi spontaneously. So now this is a question to ponder upon, and it is something like more of a humor which I have added, that you can't have cluster endophthalmitis if you operate less than 5 cases in a day. But on a lighter note, this may be a joke, but on a serious note, one should consider controlling the number of surgeries one does in a day so that the sterilization process doesn't fail, and the bulk of cases who are operated because of a contaminated solution are also limited, and you can always be on alert. Thank you.